This is part 4 of the case study C1, case discussion and conclusions. Biomechanical conclusions of the case analysis. First, and most importantly, does this case present dyscontrol? Dystonia is a medical condition that is diagnosed solely on basis of symptoms of dyscontrol. At first glance, in this musician, the right hand indeed seems discontrolled in playing. However, when taking into account that the thumb has a dysfunctional muscle, can the hand still be considered discontrolled? Or rather, is it the opposite, that the hand is actually accurately controlled in developing compensations for the defect, and that the dysfunction results not from a CNS dysfunction, but from a conflict in hierarchical priority within the central nervous system of different movement control objective functions. Notably, that increasing controllability of the joint chain in compensation of the defect has priority over task execution. In this interpretation, no pathology seems involved whatsoever, except for the defect. All generic processes seem normal. Summarized, there is a subclinical defect in the thumb muscle. This causes an uncontrolled degree of freedom in the thumb joint chain. Mechanically, there are 4 possible compensations to enhance controllability of the thumb joint chain. FPL, EPL co-contractions to generate a flexion moment at the MCP joint. Putting the IP joint into its flexion end position. Seeking external support. And then moving the thumb at the CMC joint with the MCP and IP joints in extension end positions. Amazingly, all 4 compensation possibilities were used in the musician. The first 3 in slow playing, the 4th in fast playing. Amazingly indeed, since the central nervous system developed these compensations purely by internal feedback mechanisms, having no awareness of mechanics. Eventually, the index standby support position near the thumb tip resulted in the complaint reported by the musician, the inability to timely extend the index to strike strings. In conclusion, the dysfunction in the playing task likely did not result from defective neurological control. On the contrary, the mechanically consistent movement compensations seem neurologically well controlled. In view of the above, it is unlikely that the dysfunction in playing would be caused by a combination of neurological predispositions and repetitive motion. In addition to the precise mechanics involved in this case, there is the equally compelling argument of the extreme task specificity. Even after 7 years of symptomatic slow playing, no dysfunctional overflow to fast playing had occurred. Index fast playing remained unaffected. Even thumb fast playing was not dystonic, at least there were no significant co-contractions. This extreme task specificity suggests stably compartmented CNS motor patterns. Fast motions are repeated orders of magnitude more frequently than slow motions, so repetitive motion by itself was unlikely to be pathogenic. In view of the above, the proposed final diagnosis was a highly functional hand that developed mechanically logical and effective functional compensations for a defect, which negatively interacted with the index task of string playing. The analysis also suggested that for the CNS, the objective function of establishing or optimizing control stability supersedes the objective function of task completion. What clinical conclusions might be derived from the biomechanical analysis? What would be the treatment options? Note, the treatment options here discussed are a summary of the case review at the Hand-Biomech-Ctr-Musicians. See further. surgically reducing flexor pollicis brevis dysfunction. This was considered not possible. Retraining thumb index. Retraining cannot undo the thumb controllability defect, therefore it was questionable if retraining could resolve the compensatory FPL-EPL co-contractions and the index being recruited to support the thumb. Playing with thumb splints to eliminate 1 degree of freedom in the thumb joint chain. This will be discussed in the next slides. Botox might reduce the FPL-EPL co-contraction reflexes, but was not an option at that time. Playing with thumb joint splints. Therapeutic purpose and potential effectivity. The experiments showed that splinting a thumb joint created a fully controlled thumb, albeit with one immobile joint. The splinting effectively suppressed the FPL-EPL co-contractions. The non-splinted joint could be controlled to drive string plucking, creating an effective smooth plucking motion. Despite the fact that one joint was immobile, the thumb tip trajectory in string plucking became non-jerky and highly efficient with minimal motion perpendicular to the phalangeal plane. These outcomes were similar for both the MCP and IP joint splints. Moreover, being fully controlled, the splinted thumb would not need index support anymore. This would create a real possibility for dislearning the reflexive index flexion towards the thumb tip and relearning normal index playing in slow motions. Therefore, splinting either the MCP or IP joint could be a possible solution for the playing control dysfunction. Boundary conditions for splinted playing. As a playing solution, a splint should become an integrated part of the playing technique and should therefore always be worn when playing. To be functional, a splint should fully immobilize the degree of freedom of the splinted joint. Therefore, the splint should be tightly fitted. Ergonomically and hygienically, the splint should be light, thin, practical to put on and off in daily use, and well cleanable. What splint would be suitable? An MCP joint splint would likely be impractical and not sufficiently effective. An MCP joint splint cannot be well tightly fitted given the thick, thinner, soft tissues. Moreover, the fixation over the CMC joint is complex, likely only possible by extensive taping, which in daily use might irritate the skin. However, an IP joint splint could work. The thumb middle and end phalanges are fully accessible for fixation taping. Therefore, the IP joint splint could be tightly fitted. A half-open cast splint could be taped with minimal skin contact. However, an IP joint splint must be shaped highly precisely, since it must not touch strings in string plucking. IP joint splint. Full thumb control versus performance effectivity. An IP joint splint would create a fully controlled thumb and with it the potential to retrain index playing into normal playing motions. However, the thumb then functions as if middle and distal phalanges are fused into a very long distal phalanx, while the MCP joint then functions as IP joint. It cannot be predicted how such a splinted thumb would perform as compared to a normal thumb, especially not at long term. There is also one important parameter to decide in the IP joint splint fabrication: the joint angle of flexion at which the IP joint would be fixed. This IP joint angle determines the angle of the thumb tip and nail with the string from contact throughout string release. The optimal IP joint fixation angle for string plucking would likely need to be determined by experimentation. In conclusion, an IP joint splint could create a fully controlled thumb, allowing complete normalization of index motions by retraining. However, the splinted IP joint angle would need to be optimized, and even then, thumb string playing may not be as performant as a normal thumb. Case follow-up. The case, which dates from 1998, was referred for biomechanical analysis by plastic and hand surgeon Jan Sonneveld, who directed at that time a hand clinic for musicians at the Erasmus University Hospital Rotterdam. The clinical aim of the hand clinic was determining if a case presented with factors that could be clinically or surgically treated. As part of a busy surgical department, the hand clinic for musicians did not provide long-term specialized conservative rehabilitative treatment for vocal dystonia. Since the flexopollicis brevis defect was considered not surgically treatable, the musician was provided with the diagnostic findings. The musician, who was an international patient, returned to his country without further follow-up by the hand clinic. How does the case fit the peripheral factor model? The case illustrates an important aspect of the peripheral factor model, namely that symptoms of dysfunction in musicians' hand dystonia would be factor dependent. The peripheral factor model considers different scenarios depending on the nature of the factors. The present case exemplifies scenario 5. A biomechanical defect decreasing the primary controllability of the joint chain. In that case, the symptoms of dysfunction should be most pronounced in the motions in which the control instability is most active. In the present case, paradoxically, this was when the thumb had to do nothing, merely maintaining an active unloaded standby position in wait to play its string. In fast motions, the defect could be more adequately compensated and hand function was basically normal. To conclude, the case statistics and some lessons for the clinical setting are provided. This analysis took 2 half days, in total about 10 hours. 1 half day for biomechanical diagnostics, 1 half day the next day for splinting experiments. Why so much time? A complex case. The complaint is about referred symptoms in the index while a defect exists in the thumb. The defect is clinically obscure, at least not obvious. The analysis involved advanced biomechanics. Video documentation and analysis must be made accurately. Fabrication and optimization of 2 splints. The musician needs to get used to 2 different splints in playing. Videos of 2 splints in slow and fast playing must be made. Splint video review with the musician and discussions and conclusions of the case in the hand clinic. Some lessons for the clinical setting. First, there are no standard procedures for analysis yet. The biomechanical analysis tries to identify a mechanically lawful process that links the dysfunctional motions to distinguishable hand factors. Given the diversity of possible factors, there are currently no standard procedures for this. Such procedures might be established, but this will need considerable experience. Grossly, a biomechanical analysis at the HBCM follows the schematics of this case. Second, flexible time allocation is necessary. The example illustrates that a biomechanical analysis can hardly be conducted within a fixed time slot. Some cases may be straightforward. Others, like the present case, require a considerable number of observational and deductive steps, including additional diagnostic biomechanical experiments. Specialized diagnostic setting is required. To be practical, a dedicated space is required for the hand function measuring devices, with room for a keyboard with video facilities for pianists and additional space for taking videos of musicians playing other instruments. Finally, the case also offers feedback for neurological musicians' hand dystonia research and treatment. Neurologically, hand factors are generally not evaluated in musicians' hand dystonia diagnostics, research and treatment. However, in the case here presented, the hand factor analysis suggested that hand factors did cause the playing dysfunction, and that there was no reason to suspect predisposing central nervous system factors combined with repetitive motion in the development of this dysfunction. This poses the question, in the musicians' hand dystonia population, what is the proportion of cases in which hand factors can be causally associated with the playing dysfunction? Thank you for your interest.